Thank you for taking the time to attend our presentation, Patient Identity, Why It's the Achilles Heel of Healthcare and How We Can Protect It. Our speaker today is Michelle Schneider. Michelle is a solutions engineer with Iatrix Systems, focusing on the interoperability needs of hospitals, networks, regions, and states. Michelle has participated in EMR implementations and conversions, HISP and HIE implementations, EMPI management, and interface management and testing. She is a registered nurse committed to the mission of educating the healthcare community about interoperability as a means to improve patient outcomes. Now I'd like to turn it over to Michelle to get us started.
All right, thank you, Chris. Well, good afternoon, everyone. Good morning to some of you. I think we do have some West Coasters here. So wherever you are, I hope you're having a great day. And I am excited to talk to you about patient identity today. It's something I'm very passionate about. I have been in healthcare for many years, as Chris said, and I feel like this is such an important initiative. I had the great opportunity to lead a group at HIMSS this year that was focused on the EMPI and patient identity and getting it right. And there are many missions out there for evangelists, if you will, out there trying to spread the word. So hopefully I can teach you something about patient identity today. You can leave here with some great tips on how you can start making a difference as soon as this is done, and then have a long-term plan in mind as well. So we'll start by talking about our ideal world, which is, one patient. That's great, right? We have one patient, and that patient has a unique name. Nobody else shares that name. We have our rosy glasses on, right? And that patient is a member or a patient in one ACO, so all their doctors are talking to each other, all their providers are talking to each other, and they have one EMR and one address. The patient just never moved. They're like they're a hometown person, and they stay there, and then in sickness and in health until death do you part. So that's the ideal world, right? And then we get to the real world where we have one patient who's got a similar common name to other people in this crazy world, and we end up with multiple patients with that. That patient has multiple patient identities. They're in disparate systems. We might have Meditech and Epic and Cerner and Allscripts and ECW and NextGen, and the list goes on, and they have many EMRs that they have to deal with. And of course, they have the nerve to move, and now they have multiple addresses. So as they move around in life, they now, their identity is getting more and more muted, and it's just harder and harder to really be very confident about someone's identity. And in sickness and in health, until death do some of you part. So that's the real world, as we all are struggling with these patients who move around. They go to different hospitals. They love the freedom of being able to choose, and that with that comes some risk. So patient identity across the delivery network, when you have this one hospital, and years ago I started in a Meditech hospital. We were all by ourselves in our little bubble, and we would have our single system, and we worked really hard to identify that single person. And if that person got a little messed up in there and we ended up with two, it was still in our own little bubble. So this was back in the early 90s, so we could fix it and really control the ripple effect of that duplicate identity. So now the patient is sent elsewhere for additional lab work. They have another consult visit. They get additional treatments. And our HIE, our IDN, any delivery network can now have segregated information. And it's in multiple systems for this single patient, this one person. And that's where our trouble occurs, right? So many of us are thinking about EMPIs. You might have an EMPI, or you might be thinking, geez, we really need one. We've just added on this ambulatory system. We've added on this other hospital. We're pulling in this new radiology group, and they have their own EHR. So we need to do something. So we start down that road, and right away I think a lot of us, that bell goes on, what can we do? What's our toolkit? It's our computer, right? So we think about electronic means of establishing patient identity. So we have multiple instances of the same or similar demographic information on that single patient. And it's in all those different systems, so that we want that software that's going to pull in those algorithms. And we can work with vendors to establish matching and non-matching rules. How can we get that done? And we need a process to manage that and remediate records that have been entered incorrectly and created duplicates for those matched and unmatched sets. And so we need some reporting and some checks and balances in place, right? So that's an important part of this as well. And as we get started in this conversation, we should talk about some terminology, and you'll hear people talk about just deterministic matching. And in most cases, you would consider, I know we have a lot of Meditech sites on the line, we do have some other EMR users as well, and in most cases when someone has a single EMR, it is not its own EMPI. So it would be, they would say they have patient identity, but in most cases it's deterministic or close to deterministic matching, where you use an exact match to match everything. So Michelle with 2 L's, Schneider, S-C-H-N-E-I-D-E-R. A lot of times my name is spelled with 1 L, my last name is Snyder, or Schneider is spelled incorrectly. It gets really messed up. So in a deterministic matching world, I would have quite a few different versions of myself out there. And that is probably too pure of an explanation of deterministic, but you can have some of the basic algorithms in place. You know, you might say ST is street, and those are a match. There are cases where you can do that in a deterministic environment, but in general, there are not complex algorithms that you can utilize. So a large HIE would outgrow this very quickly, as would even a network with a few different sources feeding the patient record. So an example here, and this is a little exaggerated just for example purposes, but we have 2 EMRs in those columns. You can see the column headings. We have John spelled differently twice, and in a deterministic world, those would not match. If we look at the definition for probabilistic matching, we can see that there's a statistical approach to evaluate the probability that 2 people are 2 records represent the same person. So we can use algorithms and scoring, and the algorithms get really interesting. And it's like a puzzle, which I love puzzles, so that's another reason I probably love working on these. And you really want to be confident that when you match 2 people, they are the same person. So you can't just take John and John and say, of course they're the same, that's just the first name. We have Smith and Smythe here. We have a middle name of R. We have an address that really is the exact same address, except one registrar spelled out the word south and one used S period. One registrar spelled out the word street and the other one used ST period. In the city, we have South Windsor. That's a match, but one person spelled south and one did not. So in these examples, a deterministic setting, although you can have some basic algorithms, in general, if we're using it in its most basic definition, the deterministic match would not happen, and it would say that these are 2 separate people and would create 2 MRNs. The probabilistic match with these algorithms in place, yes, indeed, it would be a match. And so then we would have only 1 MRN for that patient. So probabilistic, you can see the value there and the power of implementing those algorithms. So of course, the advantages of deterministic matching is it's pretty quick to implement, right? It's an exact match. If this matches this, then boom, go ahead and do it. So on the front end, it's less risk because you're like, no, we never match anyone who is not an exact match to somebody else. However, in my Michelle Schneider situation, you could end up with lots of duplicates. And you could have an issue where common registration errors, you can have all the policies and procedures you want. If you say south is always S period and somebody spells out the word south, then your duplicate's going to happen. So the cleanup and unmerge and merge efforts are really quite large in that situation. In a probabilistic matching world, the advantages, of course, are a lower duplicate rate, and the algorithms allow for you to really make things more efficient and decrease duplicates. The disadvantage, of course, is that this will require a lot of care and feeding. If you can imagine the algorithms that go into this, and we'll get into this a little bit more, but think of a large Asian population where many names are going to match for the Asian culture or Hispanic culture or French culture. Anyone, you're in Canada, you have a lot of similar names in that area, so you've got to account for that. You're not going to give those names as much of a score or as high of a score, and we'll talk about the reporting and the method we can use to gather that information and make those choices about matching, how much weight to give a particular matching value. So the poorly tuned algorithms can cause a big problem, of course, so you need to spend the time on that care and feeding, and time is money, time is human resources, and it's just plain old more expensive to implement, of course. So more of the terminology we'll talk about is false positives and false negatives. You can falsely match people, which we've talked about that, but you can also falsely not match people because they should have matched. So you want to talk and spend a lot of time on scoring. How are you going to score things, and work with your vendor if you decide to go the electronic route of an EMPI, and what weight do you want to give things? What does it mean in your geographic area if you have a lot of patients with a certain name, or you have a couple hundred patients in an assisted living facility? Okay, so they're going to all have the same address. We don't want to give that a really high score because we know that we have 400 people that have that same address. So we're going to consider that in our algorithms. So why does all this matter? Why is all the hubbub happening? Well, patient safety is the number one. Of course, think about some really important things that happen when if we mismatch a patient. An allergy that is not added to me because of a false negative, or is added to me because of a false positive. I could receive an incorrect drug, or a drug I need could be excluded from my use because I incorrectly have an allergy listed on my record, and maybe I end up needing a more expensive drug, or there's no other drug to choose. So there's really important patient safety ripple effect to poorly managed patient identity. Analytics, of course, these numbers, everybody's talking about the analytics, the numbers. You need to report to the state, to the federal government, to your leaders in your facilities, and so we want to make sure that these are good numbers. Think about your meaningful use submission. If you have to count me twice because I have 2 MRNs, your denominator is now inflated incorrectly, which could end up meaning you do not meet the measure when really you do. But because you have so many duplicates out there, your denominator has been inflated, and it makes it look like you are underneath the percentage that you need to pass. Trust, of course, is a big deal. You have a patient who goes to look at his or her patient portal, and they can't find information. And they're looking there, they always look there, it's always there. Well, you've created a second MRN for that person, and now it's not showing up on this patient's record because it's not going to this MRN that they're identifying with. So there are legal issues, identity theft. If you start sending a report to me for somebody else, I could use that information in a negative way. So the causes of incorrect patient matching: people, patients, as well as our healthcare workers. We're going to talk a lot about that today. One of the things that I am really most concerned about in all of this is that we do go right to the electronic means of fixing this problem. But no matter what we do, the first time the patient presents, there is almost always a human there who's our first line of defense. We have got to take care of the people part, the patients and our healthcare workers. The processes, putting strong processes in place that are well communicated, and then technology, absolutely technology. I'm not saying that that is not an important part, but if we have a bad system and we simply automate it, we have a bad system that's automated. So we need to think about what we can do. And so that brings us to our human factors in inconsistent and incorrect patient matching. And of course we have critical or trauma situations. Those are some things that we may never overcome fully. A patient comes in, they're on a bicycle, they didn't have ID, and they're in a terrible accident and are unable to speak for themselves. That's going to happen. We may not be able to fix that. We can limit our risk, but we cannot resolve it fully. Language barriers, certainly. Card sharing, this comes down to patient education. Patients think they're doing a friend a favor, a cousin a favor, somebody with the same last name a favor by sharing a card that will allow them to have a lower copay or something like that. But patients don't understand the importance of that accurate, consistent information on their long-term medical care. So, and registrars don't understand the importance of their role. We talked a lot about this at HIMSS, where there really does need to be a paradigm shift. Our registrars are usually brought in, they're trained, they get in there, and they are not as well respected as they should be. I don't think they understand their value in most cases, and hopefully, you could dispute that in your setting. I'm just going by some of the experiences that I have and the people that I've spoken with, where we are really trying to change that paradigm. Really, we need to let registrars know that they are valued. We need to re-educate them. We need to keep them engaged in this process and let them know how important that first contact is and that first identity is. So policies and procedures are not clearly communicated. We're going to talk more about that as well, and that is something, it's not about technology. We can support policies and procedures with technology, but we need to disseminate that information clearly to our staff and team. And finally, something that is really near and dear to me is that we do not hold people accountable. And by accountability, I don't mean that it's punitive and we're going to fire people. We need to give them feedback on how they're doing, re-educate them if it's needed, and then go back again a month later and show them how they're doing. Have we seen improvement? So holding people accountable for their actions and letting them know how important their role is. So this is not a fancy slide. It's just my reminder that I do need to stop for questions, because as you can hear, I just get talking and I get very excited about this. So I would like to open it up for questions. There is a questions pane on your screen. I encourage you to enter your questions there. We do have the lines muted. And let's see, Chris, do we have any questions at this time?
We do. We have one. Our registrars struggle with a large elderly population where confusion is a common reason for their visit, and we're struggling with positive ID for those patients. Do you have any good ideas for obtaining patient information in this case?
Okay. Well, that's a really good question, and it's one that we do hear a lot. It kind of goes back to the critical and trauma bullet, though, as well, because there's not a lot we can do. We can decrease the risk, though, certainly by educating our patients when they are coherent, when they are with it, encourage them to keep their ID in their wallet, make sure that they share with their family members These are my numbers. This is my information if you need to bring me in or you need to advocate for me. And from an electronic perspective, utilizing fingerprint, utilizing palm reader, iris reader, things like that that you can, if you can implement biometrics. And usually that's on a long-term goal. It is a more expensive endeavor as you're moving down this road, but certainly can help. And also considering photographs of patients during registration. So more and more hospitals are taking a photograph so that when the patient does come back in, you can confirm their identity with a picture that was taken in a previous registration. So not an exact science, certainly, unless you do have biometrics. That is scientific, but without that, education is probably your best defense, and the pictures. I've seen good luck with those as well. Okay. Any other questions, Chris?
That's all right now.
Okay, great. Okay, so I'll just keep on trucking here, and please, as we're going, if you do have a question, just enter it right in that questions pane. Okay, let's see here. All right, so now I kind of broached on this subject a little bit, and it's what can you do next week, today, tomorrow? What can you do right away without investing a ton of money? What can you do to start improving the patient identity at your facility? And registrars, I really think, are the key to getting this kicked off and getting this started, and really talking to them about how valuable what they do is to the success of the hospital, to the safety of your patients. And let other people know that too. You know, let other people in the hospital understand the value. Share use cases with them. You know, people, that is really powerful when people hear stories about how a mismatch or a poorly identified patient can result in a poor outcome. Unfortunately, you don't hear, hey, she had a great outcome because we identified her correctly, but the use cases really do, they are powerful, and they are compelling to make people want to do better. So making sure that you make time for education, have a monthly spotlight with case studies, and this is where your IT piece comes in, getting those analytics. Get some report on some of the numbers today, pull those reports, and then show them again in a month. Give people feedback. Show them, you know, this is how much better we're doing after we're making a better effort. We only had to unmerge 2 accounts, or we only had to merge 6 accounts over the course of the month, where last month it was 17, you know. So really look at that and talk to them about how important it is to take the time to get that information correct, and celebrate those successes. So the policy and procedure piece is important because, as you know, I just said, holding people accountable is really the key to this. And so we need to make sure, anytime you're going to hold someone accountable for something, we need to make sure they understand the expectations. They need to be documented. So talking to them about, we are going to get the license every single time. If a patient doesn't have a license, we need an insurance card every single time. And if it's not there, we need to document that it wasn't there and I did ask for it. You know, whatever you decide, however hardcore you decide to be, but those are some ideas of what people do to just say, no, there's no excuses. I don't care if the patient was grumpy. I don't care if they didn't want to. This is too important for the rest of their stay. So educating, re-educating, holding them accountable, and having a process in place to handle mismatches. They're going to still happen. No matter how careful we try to be, they're going to still happen. If a patient is not willing to share the appropriate information, or we are struggling to understand them and doing our best, and we've created a new patient, we need to make sure our users know, what do I do if there's a mismatch? I know it happened. make sure they know they're not going to get fired for calling and saying it happened, because I think some people get nervous, like, oh crud, I totally made a mistake, and make sure they feel empowered to let their leadership know what happened. So they need to understand the ripple effect, before they just do that initial fix and call. The people who are fixing the issue also need to understand the ripple effects. In this day and age of people having interface engines, people having flat files that go to an insurance company, or an ADT interface that goes to a lab system, or a rehab facility, or something like that. You've got a lab vendor Quest or LabCorp or something like that. You've got an HIE. As soon as that admission or registration is submitted, filed, saved, boom, that message is gone. So we need to understand that because you fixed this mismatch in your system doesn't mean it's fixed everywhere, unless there are update messages that are going. If you're doing merges and unmerges, those messages might not go. So you need to understand how your architecture is set up and how the communication works. So that's important to just educate people. It doesn't mean we can fix everything every time, but understanding the people who need to be notified and how good can we get it. Alias identity is something important to realize as well. So I had a situation where I had two patients that were merged, and I unmerged them, but in the way that our system was set up, the old name that the patient had been merged with stayed as an alias for that patient, and it was an incorrect alias, so it increased the score for matching. It made this patient look like, boy, you could be a match to that person again and again. So you want to make sure that those aliases are managed as well as they can be. In the case of a maiden name, you do want that. You want to know that my maiden name is out there so that the old medical record can mix with the new medical record, and all those, that longitudinal look will be intact. So in some cases, though, it is not great. So it can cause trouble. It can increase the matching score and end in incorrect matches. So you've got to unmerge and then, if possible, remove the match. And not every EMR has that ability. So think about, how can we flag this record? How can we make sure that we're aware of this so that if something comes up in the future, we have a way to research? Sometimes that's the best you can do, but documenting it and make sure people can follow that breadcrumb trail is helpful. So fixing that mismatch, you've got Michelle Schneider registered, and she's matched to Michelle Snyder, and Michelle Snyder is now Michelle Schneider, and then you've got to fix that. So behind the scenes, all those messages are going, insurance companies, think of disability, think of public health. So you want to make sure that when you take care of that mismatch in your own EMR, downstreams are considered. So making sure that that education happens and people know who to notify, because there could be questions later. Okay. So from the patient's perspective, it's also important to educate them, and I think that's the next most important. First, registrars, and they can help us educate patients. Certainly, we can all be a part of that process. But I don't think patients understand. They come in, they're in pain, they're anxious, they're like, my name is John. Is it Jonathan? Is it John? Does your license say John? Things like that are really important. It sounds trivial, and the patient is like, I just want my care. And so educating them about why is it so important to get it exactly right every time? And including in that some outreach. Most healthcare providers have some sort of outreach, a newsletter, or something like that, that can be used to share information, to educate patients, and set goals for how you want them to respond. Carry their ID, Maybe you have biometric registry that they can do outside of a visit to the hospital. Some people will do that ahead of time, get your fingerprint match and get your palm reading done so that when you come in, it's quick. Make sure they share information with their families and check their patient portal, check their paper for accuracy. So teaching patients how they can make sure, how they can monitor that and advocate for themselves. And then follow up and, again, re-educate if needed. You're going to see what's going great and what's not going so great. So use that as feedback for your own process and what needs re-education for your patient population. So when you're talking to patients about why it matters, decision support, let them know their physicians can only care for them with the information that's provided. If there's information that was not matched properly to their record, that missing information can cause errors. It can end up in a longer patient stay in the hospital. They could end up with, an allergy that doesn't show on their record when it should, and even the patient portal. And we talked a little bit about those messages that go out. Think of insurance. Think of military disqualification. So you have a patient who was matched with someone who has asthma, and that patient is trying to get into the military. It's been their goal, and they're trying to do that, and their record shows that they have asthma, and now they can't because not without a fight and trying to prove that they don't have it. Think of disability insurance. The cost could be through the roof if there are diagnoses on there that really shouldn't be. So that's our responsibility, certainly, and let patients know it is really important. You do not want two records out here, and you do not want to be matched with somebody else. Let's make sure it's really you. So hopefully that will be compelling information that will make them want to take the time to work with the registrar to make sure they are registered properly. So technology can really help here, of course, and the best practices really get into data governance across the enterprise. So you've got to, again, have some processes, some rules in place. Who has the last say? Sometimes when we are working to remediate records, so there's a lot of health systems, when they start to invite other sources in, that's when we will help them and show them this is what it looks like. This is the good, the bad, and the ugly, and then we go in and help them remediate those records. That remediation process is something that is really, sometimes there's low-hanging fruit, and you just go in and you can fix a bunch of them, but there's always a pretty good-sized chunk of records that need more attention, and there's sometimes groups of records that need a tiebreaker. Usually that is an HIM director, for instance, who might be assigned as the person who says in a remediation effort yes or no. And sometimes you just leave two records because you can't safely or confidently say these patients they really are the same person. So that's fine. That's the way it goes. You do need to draw that line in the sand at some point. But having a process and reporting in place, so understanding your data and what systems provide what, because I spent some time talking about having a set process on the word street, for instance. I know I bring that up a lot, but it is just such an easy thing, and we could not get compliance at any of the hospitals I worked at. There's always the person who wants to spell out street, and we just wanted it to be ST. But think about, you've got everybody doing it exactly right. Even if you did have 100% compliance, as soon as you bring in another source, they might use ST period, or they might say, no, we spell the word street. We made that decision years ago and everybody does it. Now you're bringing in those two sources with different rules, and so now you've got to kind of start again and decide what is best practice to us. What are we going to do? So thinking about that. The reporting on Social Security number, that's an easy one. You can go into your system and say, show me everybody. Everybody's got a reporting option in their EMR, whatever it might be. Find me everybody all sets of 2 or more patients who share a social. That's quick to fix. You can usually go in and find those quickly and make some matches and remove some of those duplicates. You also can find readmits, drug seekers who show up at multiple locations, and you can get a report of significant changes. This is something that I found a lot of value in, and I was able to get a report every day of anyone whose gender changed, if their date of birth changed significantly, and if their social wasn't all 9s, for example, but it had gone through a significant change. So they completely changed all the digits. And even major first name changes. Last name changes are more common, but if somebody had their first name changed significantly, sometimes it was just, I would be able to go in and see, oh, it was first name, middle name, and those 2 were swapped. And I would leave that one alone, but sometimes I would see really major first name changes, and I would dig a little deeper on those. So that's all going to help you establish some consistency in how you work through the process. So sometimes what we're seeing with the EMPI is that we have disparate and incomplete clinical information on patients across the enterprise. So that sometimes makes it hard to match. We sometimes have ambulatory EMRs, or more likely an outpatient lab, where they really don't need all the information for what they're trying to do. They don't need all of the information that the inpatient setting needs. So trying to implement some changes, give some feedback to them, and let them know that they are affecting the inpatient setting, because it does create a second MRN many times because they didn't add all of the demographic details. Sometimes there are billing duplications when these errors occur, so you end up with a second round of bills, and you can have, for instance, the mislabels, father-son confusion, and the assisted living site example, or a long-term care facility of any sort, or even an apartment building or subsidized housing where everybody has the same address. You've got to be more careful about those. So those are some of the things that those algorithms really need to consider when we are looking at matching electronically. Okay, so I'd like to just see if anybody has any questions at this point. Again, not a very pretty slide, but I will keep gabbing if I don't put it there.
We have one comment. We have problems with children's IDs, and because parents sometimes give nicknames.
Ah, very good. And that's excellent, especially when you see someone. I have a friend, her name is Candida, and she goes by Candy, and they will put that in, or Sue instead of Susan, or Suzanne. I mean, really every time, especially with children, because they don't have a license, and sometimes the health care, the insurance card, I mean, will just list the parents, and then they'll have the child as a dependent or whatever, and it's not as clear or easy. We'll just take that parent's insurance card and know that the child goes on there. So again, I would say this is a great example of registrar education. Make sure, especially with a child, if you don't have a license, can you please confirm that this is the legal name of, is Sue the legal name, or is it Susan or Suzanne, or is there a legal name that that I should document? It comes down to feedback. So that's a great example of another situation where we need to educate our staff, and maybe that should be asked on every patient. If you don't have a license, is that your legal name? Is that your child's legal name? That's an excellent point.
Very good. And then another question we have is, I have a general understanding of what the duplicate rate is, but can you explain what people use the duplicate rate for?
Sure. That's a great question. It is kind of a weird term. A duplicate rate is the number of patients who are false positives. So how many patients should be matched that are not, so false negatives, I'm sorry. So the duplicate rate is going to actually apply to sets of records, and sets doesn't have to be 2. In some cases, patients have 3 and 4 and 6 and 7 MRNs out there. Depending on the number of sources, that number can really go up. And that duplicate rate is a percentage usually. And it's used as a measurement. It's kind of a report card, if you will. So it's great to have. What we do with sites is we will provide them with a measurement of their duplicate rate. And what that serves to do is give them something to take to leadership to say, we have a problem. Or to say, look how great we are. We had one site that we worked with, their duplicate rate was 2.3%, which is fantastic. And they still want to fix the ones they can. They had some that would be very easy to fix, and they probably will get it down to around 1 after we're done. But then we've worked with some who had duplicate rates in the 20s, 24%, 25%. That's significant. The recommendation is that it is 2% is best practice. That's where you want it. So so it's really a report card, and it's a nice number to use because you can give a before and after. So if you're bringing in a new hospital or you're moving to a new EMR, that's a time when you want to know your duplicate rate especially, and then afterward you do it again and you can say, wow, we went from 14% to 6.3%. This is phenomenal. And then you can continue to monitor that over time and make sure, and it's a good way to know if are our registrars following through. Are they following that process? Are patients taking this seriously? That type of thing. So it's really a report card.
Great.
Any other questions, Chris?
That's all for now.
Okay, thanks. And we'll talk a little bit more about duplicate rate as we move on. Okay, so analytics, this gets into it as well. How can we use them to affect change? So we have the matched records and record sets that we were talking about. That's a pretty easy measurement. You may not be able to do it yourselves. You may need to enlist someone who's skilled in doing that to provide you that before and after. You usually can do that it's not an expensive endeavor necessarily. If you have things pretty well under control, it's a great way to get that report card, make sure things are going well. Generic records, understanding, I talked about the names report that I like to get in order to keep an eye on things. Social Security report, date of birth, and here I have baby girl, baby boy. Those are culprits a lot of times to cause a lot of issue with duplicates. So considering things like that are easy to check, and those are analytics that we can use. And again, we can give feedback. Okay, we fixed all of these. Let's make sure it doesn't get worse. You can run those reports in your home system and get your own report card on many of these things. And then get right down to the field level, the mother's maiden name, the previous address. Are we filling those out regularly? Because that previous address could be the tiebreaker to know if somebody is or is not a match to another record. So really helpful information there. We also, I talked a little bit about geographic, regional challenges where we have many, many patients of the same ethnic background, and that's where we see a higher number of the similar or same last names or first names. So that's important. We start to see human errors that are uncovered. We have, our policy is to south is always S period, and we have some doing it and some not. So those errors can be uncovered, and we can give feedback. So we can show those improvements over time, and that's what people respond to. When they start to get the positive feedback, celebrating the success, showing them, I am looking, you are doing better, we appreciate what you're doing, it makes a big difference. So understanding where all the data is coming from is also very important. So understanding the acute care and ambulatory EHRs, what are their policies? We talked a little bit about that. Understanding the interfaces. Where are those ADTs coming in from? What other EMRs are contributing? Physician practices. What about those labs, RADs, those skilled nursing facilities? Who's sending us flat files, and are we converting that into discrete data that is populating our patient data? Order messages that can turn into ADT messages. We can do some tricky things in an interface engine or with an interface that could affect our bottom line as it relates to patient identity. So understanding those sources is really important, and certainly CCDs, CCDAs, those types of standardized documents coming in can also affect patient identity. So understanding, have you ever converted from another EMR? Is there, tons of information that came from an old EMR that was not well managed as it relates to patient IDs? So understanding if it's good data is important. So you're striving for all those fields to be complete, registration interfaces, CCDs. Really think proactive. Think about what's coming, personal devices, integrating those. How do you want to set yourselves up in order to be prepared for that type of integration? So if you don't have an EMPI, you want to think about, as you add sources, what are my risks and what can I do to mitigate those? And then if you do have an EMPI, if that duplicate rate is high and getting higher and you're adding sources, it could be because those algorithms are outdated and need to be reconsidered and reevaluated. So getting those facts about the potential duplicates, understanding that duplicate rate, and how often is this happening? Is it the same person whose name is on the event log every time? So why does this happen? Is it simple name differences? Are we talking socials that are entered incorrectly? Are we talking those fields like baby boy, baby girl? So this is our opportunity to use those facts to make sure that people understand what they're doing and why they're doing it. And then we do want to get some data. We want to be able to show our leadership. We want to be able to show our staff, this is what we're looking at every week, every month, every year. And we want to see this improve. So we get that duplicate rate and we start to think about how many records are we looking at, how many of them are, probably a duplicate, and if we fix those, what is it looking like? What kind of work do we have ahead of us to resolve this? And then we can take that data and really think about, we can show people the data in different ways so that they can use it to make decisions. Our leadership might say, yes, this is worth investing in. We can see the problem. We can see that there is an absolute ability to improve a certain percentage by investing a certain amount of money or time. Sometimes it's just resources that you need to invest in order to resolve something, or it's worth an initiative to change our processes. So being able to look at these and show how many of these records will be affected by this change. And so I'm not going to belabor this. We talked about adding new sources, stepping back each time. Really look at the geography again, look at the policies and procedures of the source you're adding, and how is it going to affect yours that you've worked so hard, your baby, to keep safe, and then really think about what does it mean and talk before you just send a whole new source and a whole big bunch of demographics into your system. So sometimes the generic IDs, I talked about baby girl, baby boy, those socials, 99999. We had all nines for socials that were unknown. That was it. As we started looking at these, in most hospitals you'll find that they end up with zeros, they end up with ones, they end up with 1, 2, 3, 4, 5, 6, 7, 8, 9. You get people who decide their own method of doing that, especially as you start to lose your grip a little bit on the registrars, because it's not just your tight-knit group. As you add ambulatory offices, those people might not even work for you. They might report to somebody else, so the physician office might be part of your network, but they are not under the, they're not a staff member of your admissions registration HIM department. So when we talk about generic data, we're talking about two categories: the trait level, so that's right down to the data element, and then we talk about the record level. So that's a combination of the trait level generic values, and they're combined to exclude the full record from matching. So you might just decide that we're not even going to try to match that one. So as we look at that, we have generic names, and we can see how many times they're used. So using reporting, you can see that there were 465,000 plus that were all 9s. Well, with that many generic socials, you've lost a really important part of the puzzle in your matching. So you can see there that, you know, maybe an effort needs to be put toward trying to refine that and get those more exact. Baby girl, baby boy. In most cases, people have, you know, baby girl Jones, but you can see they also have baby Jones. And I worked at a hospital on an EMPI project where they had many different, they had baby space girl, they had baby girl with no space, they had girl, they had baby, and then when it got into multiples, twins, triplets, the naming got really messed up with the 1, 2, 3 for the multiples, and there was no rhyme or reason. So it was something that we really had to step back and spend a lot of time, and it seemed silly, like just type baby girl. And it had kind of taken on a life of its own and caused some trouble. And even the generic date of birth. So when people don't know a date of birth, again, in this case, it looks like 1/1/1901 is the chosen unknown generic date of birth, but then you have all those others. When you have that many of the same, so the 1/1/1900 has 222, and 1/1/1901 has 202. So your algorithm, you might have said to it, if it's 1/1/1901, don't give it any credence, but all of these others that have been used as generics will be given a normal weight scoring if people just go off and do their own thing, and that puts them at risk of incorrectly matching patients. So it is very important for people to follow those policies and procedures. So we also need to look at the skeletal record, and basically that's going to allow us to look at each component of a record, not just, you know, the name, the first name, the last name, and all of the address components, things like that. And we can see how things are made up so that it allows us, using your database, to decide the weights. So if you're talking about an EMPI, so you're using an electronic way of matching, you use that data to help you decide how much weight to give something. So for instance, if you had a bunch of patients that, again, were missing last names, or you have a source that is really bad at putting in the Social Security number, or they're really bad at putting in the birth date, what's the percentage of times that piece of information is completed? And how often are these unique? What is the percentage? It will really help to determine those algorithms. So those are some of the things that you want to look at and say, how well are we documenting that field? Because that field will be an important field in making sure that we match patients properly. So think about that previous address. That can really help. If that matches or does not match, that could really stand out. And talking about our geography and what it says about us, we've talked about that a little bit. And all of these details, anything that you can use, even if it isn't with an electronic method of matching patients, but you're teaching your registrars that, you know, we have a very large population of this particular particular ethnic background. So we anticipate, when somebody comes in with the last name of Smith, we know that we have over 14,000 patients with the last name of Smith. Please take extra time and ask them more about themselves. Make sure you get push for that license. Do your best to get what you can. So it will really help if your staff members understand what that looks like as well. What does the geography say about them? Is, really looking at that, and if they can have the tools to help stop any of those errors, then that is fantastic, of course. So when we look at an extract from a hospital, again, this is something you could pull in a report. These are not difficult things. Getting last names and getting the count, getting first names and getting the counts. Created date is also important. If you have 10,000 patients that were created in your system on the same day, then that's probably the day that that patient, that you had a new EMR, a new source, or maybe that was the day that you converted to a new EMR and moved all of your patients to the new system. Those dates are important because that can help, again, that can help stand out and make sure that okay, that came over in the conversion, so that was probably not as reliable. Think about those addresses. We have Manchester Manor here, has over 1,000 patients with that address. If it's a rehab center, they may have been in that address for months. It was in there, and now they could be in a different address, but that address is part of their history. So we don't want to give that address as much credence because so many people share it. So that's probably not going to be a great tool for matching, whether we do it manually or electronically. So when we think about the best practices for managing our EMPI, we need to think about our remediation efforts. Whether you are staying with your current model, which might be manual, deterministic, you just have your EMR, and electronic EMPI is not on your horizon anytime soon, but you know that you might have a mess on your hands, you really should consider getting those reports, aligning with somebody who can help your hospital get those reports so that you have what you need in order to move forward with remediation efforts. So they can tell you these 3,000 patients are probably duplicates. And then you can take that. I worked with one hospital and they said, we just want to purchase the report time that you spent, and we want the information, but we're going to remediate on our own. Other people don't have the resources to do that, and they might say, no, we need that remediation. We need to, get someone to do that. So those are your options. So you can resolve those efforts, but then, of course, keeping it clean. That is the real challenge here, right, is fixing it, understanding what went wrong, hopefully putting some processes in place to make those changes, educating those end users, and all of those things we've been talking about, making sure that we understand that. And something that we didn't spend much time on, but that is so important, is merge and unmerge management, and really having a process around that. Who does it? Who's allowed to do that? And when you do merge and unmerge, which is a very good thing, in most cases, having the ability to do that in your system, you also need to understand that because you unmerged it doesn't mean that the downstream systems can accept an unmerge message or a merge message. So if you're a member of an HIE, if you're a member, or you're sending to a lab system, or you're sending to even your ambulatory system, just understand that. It doesn't mean you can decide what you want to do with that information, but it's important to know that just because you did that in your own system doesn't mean the messages are accepted by the downstream applications. So certainly there are benefits of an EMPI for your workflow. You can remove duplicates from your existing system, and that helps registration, of course. You've got accounting that is benefits by this, providers. And just from a meaningful use perspective, all around you've got some great benefits. So I'm going to go ahead and close out. I will stay on the line for questions if anybody has any. I know that that I went right up to the end here, so I'm sorry. And I will stay on the line if anyone has questions, or please feel free to email me at michelle.schneider@iatric.com. And I'd like to remind you that you will be prompted to fill out a survey when you close out of the webcast. And so please take the time to fill that in. That really helps us a lot, and we rely on your feedback. And you will be entered into a drawing, of course, too. So that's a nice little bonus. So thank you, everybody, for your time. If you need to leave, I understand. But again, I will certainly stay on the line if you have any questions. And I am going to stay on the line, but I'll just put up this last slide so that you can see the details of how to contact us. Okay, I don't see any questions popping up. Chris, let me know if you have any in your view.
I don't see any either.
Okay. Okay, well, I think we'll go ahead and close out then. So thank you, everybody, for your time. I really appreciate it, and I hope you have a wonderful day.